So today I have the privilege of introducing Dr. John Ayanian, who will introduce the two speakers for today's Dean's Frontier Seminar. Just by word of introduction, Dr. Ayanian is the Alice Hamilton Professor of Medicine, Professor of Health Management and Policy, Professor of Public Policy, and a practicing general internist. He is also the inaugural director of the Institute for Healthcare Policy and Innovation. And this includes over 500 faculty members from 14 schools and colleges at the University of Michigan. Among his many notable accomplishments, he has served as associate editor of the New England Journal of Medicine, and he's an elected member of the National Academy of Medicine. And currently, he's leading a team of over 15 faculty members conducting a federally authorized 5-year evaluation of the Healthy Michigan Plan, which has expanded Medicaid coverage to more than 650,000 adults in Michigan. So please welcome Dr. Ayanian.
So it's my pleasure to welcome all of you on behalf of the Institute for Healthcare Policy and Innovation. We're one of the university's newest campus-wide institutes with over 550 faculty members, about 2/3 of whom come from the medical school, 1/3 come from 13 other schools and colleges across the campus. And today we're honored to be invited by Dr. Omary to present on healthcare policy and innovation, and one specific aspect of that, which Dr. Jepsen referenced, which is the work that our faculty are doing on the Healthy Michigan Plan, which is the expansion of Medicaid to over 650,000 adults in the state of Michigan, many of whom were not getting medical care and were facing significant medical bills before they gained Medicaid coverage. So we have two of our most talented faculty members who are conducting some of that work, Dr. Renuka Tipirneni from the medical school and Dr. Sarah Miller from the business school. Dr. Tipirneni will speak first. I just want to introduce her briefly, and then we will shift to Dr. Miller and then open it up for discussion with all of you. And we hope to have take your questions and thoughts about the topic that we're discussing today. So Dr. Tipirneni is an assistant professor of internal medicine and a member of the Institute for Healthcare Policy and Innovation, or IHPI, here at the University of Michigan. And her clinical practice focuses on both primary care and hospital medicine. And she practices both at Michigan Medicine and the VA Ann Arbor healthcare system. She completed her undergraduate studies at Cornell, her medical school training at the University of California, San Francisco, her internal medicine residency at Massachusetts General Hospital. She joined the University of Michigan faculty 3 years ago after completing her postdoctoral health services research training in the Robert Wood Johnson Foundation Clinical Scholars Program here at the U of M. Her research focuses on investigating the impact of health reform, policies and programs on low socioeconomic status adults, aging, and other vulnerable populations, and the delivery of care in the healthcare safety net. Her current work examines access to care under health reform, Medicaid policy, including behavioral and physical health care, and assessments of social determinants of health in clinical practice. She's co-investigator on our IHPI evaluation of Michigan's Medicaid expansion, principal investigator evaluating the Medicaid Health Home program here in Michigan, and a recipient of a K08 Career Development Award from the National Institute on Aging, examining the impact of coverage expansion on near-retirement adults. Today, she'll be speaking on what happens to patients after Medicaid expansion, changes in health and ability to work. Dr. Tipirneni.
Thank you to Dr. Ayanian for the introduction and to Ms. Shah for presenting this and to all of you for attending. I want to focus today first on the health effects on individual enrollees, or what happens to patients after Medicaid expansion. So let's start with a little bit of background on the Affordable Care Act. Depicted here is the three-pronged approach to coverage expansion under the Affordable Care Act. The first prong is the individual mandate, which forces people to buy insurance or pay a penalty, as well as the associated employer mandate, which mandates that employers with over 50 workers offer insurance to their employees who work at least 30 hours a week. Many of you may have heard that the penalty associated with the individual mandate was recently repealed as part of the tax reform legislation in December of 2017. And overall, this individual mandate affected a smaller proportion of the newly insured. The second prong of this approach was new exchanges offered to middle-income individuals. These exchanges are marketplaces for middle-income individuals to purchase individual health plans on sites such as healthcare.gov or state-based exchanges. There are forms of financial assistance available to these individuals, including tax credits, and subsidies when purchasing individual health plans. The last or third prong of this approach is the Medicaid expansion, which expanded this program previously offered to only certain categories of low-income individuals to all low-income adults, and this will be the focus of our discussion today. Medicaid expansion under the Affordable Care Act started in 2014, and at this point has expanded coverage to between 11 and 15 million non-elderly low-income individuals nationally. Initially, the federal government covered 100% of the costs of this program in 2014 to 2016. This decreased in 2017 to 95% of the costs and will continue to gradually decrease to 90% of the costs by 2020. Just to put this into perspective, this is a far more generous federal match than the traditional match that's in the range of 50 to 70%. So before the Affordable Care Act, many low-income individuals were not eligible for Medicaid coverage. The federal government only required that states provide Medicaid to people with certain qualifying conditions, such as those seen here on the left. These qualifying conditions included people with disabilities, elderly individuals living in nursing homes, children, pregnant women, and certain types of parents of dependent children. As you can see here on the right, the Affordable Care Act expanded that eligibility to include coverage for low-income, childless, non-disabled adults. However, after the Supreme Court decision in 2012, Medicaid expansion became an option rather than a requirement for states. Since then, 33 states plus the District of Columbia have decided to expand Medicaid, and actually updated just this month since this map was put together, Virginia's legislature recently passed their decision to expand Medicaid. I also want to point out that 8 of these expansion states in blue, and those indicated with the circle in red, have federal Section 1115 waivers that allow them to make state-specific modifications to the Medicaid program. Michigan is one of these states with a special federal waiver. Medicaid expansion in Michigan was passed by the legislature and signed by Governor Snyder in September of 2013. Known as the Healthy Michigan Plan, the program began enrollment on April 1st of 2014. And since that time, over 680,000 non-elderly adults aged 19 to 64 with incomes up to 138% of the federal poverty level have enrolled. To put this into perspective, this was way more than the 322,000 that were initially projected to enroll in the program. And it's consistent with national trends of greater enrollment in Medicaid expansion programs than what was projected. The Healthy Michigan Plan has several distinctive features that were approved under the special federal Section 1115 waiver. These include the expectation that enrollees obtain an early primary care provider appointment within 60 to 90 days of enrollment. In addition, completion of a health risk assessment with that PCP is strongly encouraged through financial incentives. And for those enrollees with incomes over 100% of the federal poverty level, they're required to make premium-like contributions. In addition, copays for services and all payments are made into what the state calls My Health Account, which resembles somewhat a health savings account. I wanted to point out that Michigan is pretty unique among expansion states for several reasons. First, it's one of the few Republican-controlled states that decided to expand Medicaid. And as I mentioned, it's also one of the 8 states with special federal Section 1115 waivers that allow state-specific modifications to the Medicaid program. And these include increased cost sharing for some enrollees and financial incentives, as well as accounts resembling health savings accounts. As a purple state, Michigan may be a model for political compromise. I wanted to also highlight some recent policy developments and put them into perspective in our state. So, requirements for individuals to work as a condition of eligibility for the Medicaid program have been proposed by several states, but for the first time in the history of the Medicaid program, were recently approved by the federal government. The Centers for Medicare and Medicaid Services made a big announcement in January 2018 encouraging these work or, quote, community engagement requirements. Since that time, 4 states have had federal Section 1115 waivers approved with a work requirement, and these are Kentucky, Indiana, Arkansas, and New Hampshire. Proponents of work requirement policies have mentioned concerns about, quote, able-bodied adults remaining on Medicaid and not working. Opponents of these policies say that work requirements are not consistent with the Medicaid statute, which has an aim of improving health for low-income individuals. And this is actually the subject of an ongoing lawsuit in Kentucky, for which we may expect to hear some initial findings by that court soon. However, prior research in this area is limited. Recent national studies have found no impact of Medicaid expansion on reduced employment, working hours, or early retirement at a population level. However, at the individual level, the effect of expanded Medicaid coverage on enrollees' ability to work and seek employment is less certain. So under contract with the state of Michigan as the official evaluators of the Medicaid expansion program, the team at the Institute for Healthcare Policy and Innovation and I conducted surveys and interviews of Medicaid expansion enrollees in 2015 and 2016. We asked enrollees about their perceptions of changes in health status, their ability to work, their ability to seek a job, and their current employment status. We first asked which Medicaid enrollees are working, and do certain health conditions keep some enrollees from working? So as you can see in this pie chart in blue, almost half, or 49% of enrollees were working, and then if you see the other colored bars here, a total of 12% were homemakers, students, or retired. 11% reported that they were unable to work, and 28% reported that they were out of work. We then looked at health conditions among enrollees in each employment group. Among those who were out of work, depicted here in green, 33% had fair or poor health status, and 25% had a mental or physical health impairment that affected them more than half the days of the month. Among enrollees who were unable to work, depicted here in yellow, 73% had fair or poor health status, and almost 70% had a physical or mental health impairment. Among enrollees who were employed, depicted here in blue, 20% had fair or poor health status, and less than 15% had a physical or mental health impairment. So compared to employed enrollees, if we look at those who are out of work or unable to work, they appear a lot sicker. And actually, what was striking to us was how large a difference in health status there was between these groups who are working and not working. Next, we assessed the impact of obtaining expanded Medicaid coverage on enrollees' health and subsequently their ability to work and seek employment. We asked, what are patients' perceptions of changes in health and job outcomes after gaining Medicaid coverage? Since enrollment in the Healthy Michigan Plan, 47.8% of our enrollee respondents reported improved physical health, 38.2% reported improved mental health, and 39.5% reported improved dental health. Enrollees who were currently out of work were asked their agreement with the statement, having health insurance through the Healthy Michigan Plan made me better able to look for a job. 54.5% strongly agreed or agreed with this statement. Enrollees who had a recent job change in the past 12 months were asked their agreement with the statement, having health insurance through the Healthy Michigan Plan helped me get a better job. 36.9% strongly agreed or agreed with this statement. Next, we examined the association between improved health and enrollees' reported employment status and ability to work. We found that there was no association between reports of improved physical or mental health since enrollment and current employment status. However, employed enrollees with improved physical or mental health since enrollment were over 4 times more likely to report that the Healthy Michigan Plan helped them to do a better job at work. We also examined the association between improved health and enrollees' reported ability to seek a job. For enrollees who were out of work, those with improved physical or mental health were almost 3 times more likely to report that the Healthy Michigan Plan helped them or made them better able to look for a job. For enrollees who had a recent job change, those with improved health were over 3 times more likely to report that the Healthy Michigan Plan helped them get a better job. In interviews with enrollees, Several Healthy Michigan Plan enrollees attributed their ability to get or maintain employment to improve physical, mental, or dental health because of services covered by the Healthy Michigan Plan. For example, this enrollee comments on improved physical health. If you don't know you got it, then you don't know what's causing your ailment, and you're not able to get the medications that you need or the care that you need, then that prevents you from being employable. I start school on the 22nd for a semi-truck driver, so I plan on driving trucks, and I need to know what's going on with me if I'm being careful myself on the road as well as others. This enrollee comments on improved mental health. I have personally gotten better since being able to seek help for my mental issues, and that falls out over the rest of my life. I'm happier, I'm more able to work, I can function. This enrollee comments on improved dental health. My teeth were pretty bad, and they fixed it up fine, and now I feel better when I am looking for a job. I feel better because my appearance has changed a lot. That has helped me a lot, physically and mentally. Remaining barriers to work cited by enrollees included older age, disability, illness, and caregiving responsibilities. This enrollee comments on persistent poor health. Right now, I haven't been able to work, so I'm kind of slowed down by the illness. I don't have cancer anymore, but I'm going through post-treatments, and I have to start going through physical therapy. Once I'm done with that, I'll probably be able to return to work. It's actually good that I have Healthy Michigan, because like I said, my job doesn't cover anything like this. So in summary, these study findings showed that most Medicaid enrollees were already working or in school, and enrollees who were unable to work reported significant barriers to employment, such as poor health, chronic health conditions, or functional limitations. In addition, expanded Medicaid coverage was associated with reports of improved health, improved ability to work, and to seek employment. So the bottom line for these findings are that work requirements would likely only apply to a small group of individuals and may disrupt care for many chronically ill individuals. So how do these findings inform the policy debate over work requirements in Medicaid? As I said, work requirements have never before been a condition of eligibility for a public insurance program in our country. However, since the announcement by the Centers for Medicare and Medicaid Services in January, 4 states have already received approvals for work requirements in federal Section 1115 waivers, and those are depicted here in light blue. In addition, there are several other states with pending waiver applications to the federal government, depicted here in navy blue. And what's not depicted here are the many other states considering these proposals who have not yet submitted a waiver application. That includes Michigan. Our legislature just earlier this month passed a bill that would include a work requirement in the Healthy Michigan Plan, and it's anticipated that the governor will likely sign that bill. What's also not depicted is some non-expansion states considering this in their decisions to expand. As I said, Virginia very recently expanded Medicaid, and part of that decision depended on this work requirement being part of the bill. So I think early experiences from states implementing these work requirements in Medicaid may inform other states' decisions about whether or how to implement similar work requirements. Thank you.
Thank you, Dr. Tipirneni. And we'll hold questions till after Dr. Miller's presentation and open it up for questions of both speakers. So Sarah Miller is the Sanford Robertson Assistant Professor of Business Administration at the Stephen Ross School of Business here at the University of Michigan, and also a member of the Institute for Healthcare Policy and Innovation. She received her PhD in economics from the University of Illinois in 2012. She was then a Robert Wood Johnson Foundation postdoc in health policy research here at the University of Michigan, and served as an assistant professor of economics at the University of Notre Dame before joining the faculty at the University of Michigan in 2014. Dr. Miller's research focuses on health economics, and in particular the short-term and long-term effects of public policies that expand health insurance coverage. In addition to her work on health economics, she's also a principal investigator on the Y Combinator Basic Income Randomized Controlled Trial. Her work has been published in the New England Journal of Medicine, the American Economic Journal, Journal of Public Economics, and the Review of Economics and Statistics. Her work has also been cited by the New York Times, Wall Street Journal, and the Economic Report of the President. Dr. Miller will be speaking on the financial consequences of the Healthy Michigan program. Please join me in welcoming Dr. Miller.
Great. Thank you so much for that great introduction and for having me here to talk about my work today. So I'm going to discuss work that's joint with some colleagues at the Federal Reserve Bank of Chicago, Northwestern, and the University of Illinois. And we're looking at the financial consequences of enrollment in the Healthy Michigan program. Part of our motivation for thinking beyond just the health or the labor market consequences that were just discussed is that many times when policymakers opt to expand public coverage to different groups, often the rationale that you hear is not necessarily to improve health, but to provide some financial protection for individuals who will benefit from these policies. For example, at the signing of Medicare, President Johnson said, "No longer will illness crush and destroy the savings that older Americans have so carefully put away over a lifetime." He was evoking a very financial rationale for offering this program. And similarly, President Obama in the 2014 State of the Union, that's what health insurance reform is all about. The peace of mind that if misfortune strikes, you don't have to lose everything. So in one sense, our work is asking, did this Medicaid expansion through the Affordable Care Act deliver on this promise of improved financial security to those who benefited from it? So we just heard a great discussion of the Healthy Michigan program, so I won't go into details on this, except to say that in order to conduct our analysis of the impact of the Healthy Michigan program on financial outcomes, we partnered with the Michigan Department of Health and Human Services to match Healthy Michigan program enrollees to their credit reports. We worked with the Department of Health and Human Services on one side and with TransUnion on the other side. This match was conducted using a double-blind matching method that prevented TransUnion from identifying who was enrolled in the Healthy Michigan program and also prevented me, the analyst, from having access to personally identifiable information. And I'm happy to give more information on that double-blind method, but I just wanted to say up front that we did this sort of with a lot of sensitivity to protecting the privacy and confidentiality of enrollees. So TransUnion provided information on credit reports, and the Michigan Department of Health and Human Services provided information on health services, enrollment, income, and some demographic characteristics. The information on services that we received from the Healthy Michigan program was the number of hospitalizations and emergency department visits that were experienced in the first 12 months of enrollment, the presence of a chronic illness on a diagnosis code on one of the encounter claims that occurred during the first 12 months of enrollment, and some demographic information such as age. From TransUnion, the credit report contains sort of thousands of variables on borrowing and delinquency behavior. We focus on a few of these variables that we think are capturing sort of financial problems or financial distress in the household. In particular, third-party collections, which is what occurs when you have a bill that's past due that you just don't pay. Eventually, your original creditor decides that they're not going to be able to collect on this bill, and they send it to a third party to try to collect on it, sometimes for pennies on the dollar. So these third-party collections can be hospital bills, other medical bills, utility bills, or they could be severely derogatory bills from like a credit card. For example, if you had credit card debt and simply stopped paying your bill, eventually this would go into third-party collection. So in addition to that, we also looked at other types of credit market delinquencies that were on accounts that enrollees had open. So if you have a credit card and the account is still open and you're not paying your bill, even though it hasn't gone to a third party yet, you could still be delinquent on that bill by 30 days or more. In addition, we look at other types of measures of delinquencies, such as public records. These occur anytime you're interacting with the court system and you have sort of a negative financial situation. For example, if you're sued for child support, if you are experiencing an eviction, or if you're going through bankruptcy, these would all show up as public records on your credit report. So we observed this credit report data biannually starting July 2011 through January 2016. So we see sort of a long period prior to the enrollment in Healthy Michigan and then a post period as well. So we're excluding people that previously had a state benefit plan prior to Healthy Michigan, since they weren't necessarily moving from being uninsured to having insurance. And of course, we also have to exclude those not matched with a credit report. This was initially a very big concern in our study, that a lot of people wouldn't have credit reports. It actually turns out that we were able to match over 90% of all enrollees, and that for the most part, what was predictive of being not matched was age. Okay, so let me give you a little bit of information about what the credit report situation looks like for people that are enrolled in Healthy Michigan. So the first thing I want to say sort of before diving into these descriptive statistics that are derived from the credit report is I'd like you to bear in mind that these individuals tend to be quite poor. Average income upon enrollment in the sample was about 40% of the federal poverty level. For a family of three, that's about $8,000 a year. For an individual, we're talking about under $5,000 a year. And so I think bearing that in mind makes these descriptive statistics quite shocking. I guess I don't really know a better word. So on average, prior to the Healthy Michigan program, they had about $1,800 in third-party collections in total. About $900 of that were medical bills. Right? So quite a substantial amount of bills that are severely derogatory. Now, in addition to these bills that are in collection, on their open credit accounts, they also had about $845 on average that was past due. That's in addition to the total collections. On average, they had about 0.4 public records. Again, remember, public records are evictions, judgments, and bankruptcies. And if we look specifically at bankruptcies, they had about 0.1. Just to give you a sense of comparison, this is over 10 times what an average credit report would show in terms of number of bankruptcies. For all of these sort of measures, if we just kind of do a simple look at the simple difference across time, we see a reduction in delinquencies, indicating an improvement in financial health. Let me show you also some statistics that were given to us by the Healthy Michigan program. These don't vary pre-post, we just see them once. So you can see we have we have very high match rate with the TransUnion credit report, on average about 39 years old, 57% female, and again, as I mentioned, 38.8% of the federal poverty level as is their average income. There's quite a large mass at zero, with zero income. On average, about 0.14 hospitalizations per year, about 0.96 emergency department visits, and about 70% have a chronic illness. Okay. All right, so let me show you sort of the main analysis that we did. I'm going to take just an extra minute to explain this figure because most of my figures going forward are going to be pretty similar to this one. Right? So what I've done is I've showed on the y-axis here, or sorry, the x-axis here, when we observe their credit report relative to when they enrolled. The vertical line indicates the month in which they enrolled in Healthy Michigan. And so the observations that are to the left of this vertical line are prior to enrollment. What did their outcomes look like? Now on the y-axis, I've put whatever the average is of the outcome variable, and I've normalized it to be 0 the month prior to enrollment so that we can look at relative changes from the baseline. Right? So in this case, we're looking at third-party collections. So this is the first variable that I discussed, the total amount that is in third-party collections. And what you can see is that it's relatively flat, although slight trend downward prior to enrollment. But then after the individual enrolls in Healthy Michigan, there's a very stark sort of change in the slope of this line, and it heads downward sharply. By the end of the period, when you compare the amount in third-party collections that the individual has relative to what they looked like right before enrollment, they have about $538 less in third-party collections on their credit report. And that's highly statistically significant, and I should mention these are 95% confidence intervals, and so you can easily do the inference. Medical collections in particular, I think, show a quite dramatic decrease after enrollment. Prior to enrollment, we don't see really any trend. It doesn't look like they're undergoing any sort of improvement over time in terms of their medical collections on their credit report. And then at the time of enrollment, there's a very dramatic change in the slope, and you see medical collections decrease quite a bit by the end of the period by about $515 on average. Amount past due, this is the amount that's not in collections but is on an open account that you have, so like a credit card that you're not paying, again, we see kind of no evidence of any improvement prior to enrollment, and then after enrollment, a decrease in the amount past due that totals about $233. And then public records, I think this is a very interesting variable because I believe this captures sort of very severe negative things that can happen to an individual in terms of their financial situation. So things like evictions, bankruptcies, and judgments. Tax liens would also be in here, and wage garnishments. So you should think of this as sort of relatively extreme events that happen when you're getting pushed close to bankruptcy. And what you can see is, again, not really any visible sign that things are improving before, and then once enrollment starts, we see an improvement in the form of a decrease in public records of about 0.07 per enrollee. And then finally, I think medical bankruptcies is always sort of the hot topic to discuss and be concerned about, and for good reason. So bankruptcies are more rare than public records by about a factor of 4. But again, we see a decrease following enrollment. And by the end of the period, we're looking at a decrease in the number of bankruptcies on average on enrollees' credit reports of 0.001. It's statistically significant. And if you recall the baseline means I put up, it's about a 10%. Okay. Great. So that's the results for all enrollees. And I think we see pretty clear evidence that there are improvements in financial outcomes. The next thing that we do is we take advantage of this very rich data that was provided to us by the Michigan Department of Health and Human Services, and we look at whether or not there was heterogeneity in this effect based on some observable characteristics of enrollees. I'm going to show you the effects for medical collections, because for medical collections, this is where we see very stark differences. So for the other outcomes I showed you, we see relatively similar improvements among all enrollees, but medical collections, we see that there's really differences in different subgroups. Okay, so the first pair of subgroups I want to show you is for individuals that had a hospitalization or an emergency department visit in the first year versus those that did not. Now, to prevent this graph from being way too busy, I have truncated it, and I'm only showing you the portion that is occurring after they enroll. Right, so I'm not showing you the pre-period here, and that's mostly just so that there's not too many dots on the screen. But the blue line is the effect on those that did have a hospitalization or emergency department visit, and the black line is the effect on those that did not. And what you can see, I think there's two interesting things. First, you can see very clearly that those who are supposedly in worse health because they're using hospital and emergency department services are experiencing much bigger benefits in terms of reduced collections. But even among those who are not using the hospital, there do appear to be statistically significant benefits. They're just not quite as large. The second level of heterogeneity that we look at are those that do and do not have a chronic illness reported in their encounter data in the first 12 months of enrollment. And here we see a very similar pattern. So we see that those that have a chronic illness are experiencing much bigger improvements in terms of reductions in bills, medical bills and collection. But even those that do not have a chronic illness are still seeing some benefit. And sort of the last interesting cut of the data that we do is we look at individuals for whom Medicaid is the only source of payment for any health care versus some who have individuals who have some third-party liability. This is often workers' compensation, for example, or it could be a standalone dental or vision plan that they've purchased. Those that have Medicaid as the only source of payment see by far a bigger benefit of enrolling in Medicaid in terms of reductions in unpaid bills. Okay, so that's our main results. I think the takeaway is that I guess, first of all, those that enroll in Healthy Michigan tend to be in a difficult place financially, which is perhaps unsurprising because they're enrolling in this program for low-income individuals. But upon enrollment, they see very large and growing improvements in a lot of these measures of financial well-being. We see large reductions in delinquencies. For open credit accounts, we see reductions in the balance of bills that are in collections, and even see reductions in extreme and fairly rare credit events like public records and bankruptcies. Beneficiaries who appear to be most disadvantaged or most in need of the health insurance seem like they're benefiting more, but even those who are relatively healthy are experiencing some benefit. And I guess the last point that I'll leave you with is we can only see a certain amount of time after enrollment, 21 months after enrollment, is when our data end. But based on the figures, it looks like these effects are not only big, but they're getting bigger over time. And so I guess one more takeaway that I'll leave you with is that not only should we be thinking about this program as something that's benefiting people's health and their access to healthcare services, but it's also something that's benefiting their financial well-being. Thank you for your help.
So thank you to our two speakers for excellent presentations. I want to kick us off with a couple questions to the two of you, then we'll open it up for the group as a whole. The first question is, I wonder if you could reflect on each other's presentations and sort of the data that you presented, Renu, on sort of ability to work, people reporting that they can potentially do a better job at work or get a new job or get a promotion. And Sarah, sort of your perspective on how much of what you found might be the direct effects of Medicaid's now paying for people's medical expenses versus some of the secondary but very desirable effects that people are either able to work for a higher salary or work more hours or get a job, period. And that may be part of why they're facing less problems with their credit scores.
Yeah, I'll go first. Renu, I thought your presentation was extremely interesting and informative to my own work. If we had just seen effects on medical bills, for example, then I would have interpreted this to be, very beneficial, but in a sense, very mechanical. If we had just seen effects on medical bills, I would have thought, well, this is just because the program is paying for it. But the fact that we see effects on kind of credit card delinquencies, on things like evictions and bankruptcies, suggests to me that there's a bigger picture going on. And I think a lot of that can be in these labor market outcomes that you're finding in your survey.
And I agree, Sarah. I think there's a close tie between our work, and I would say that a lot of what we're thinking about is the upstream and the downstream effects of this program. And so upstream, people are coming in with lower incomes, perhaps sicker if they've been delaying medical care. So what we're seeing at an individual level is improvements in these reports of health. And does that actually make the translation, whether it's through employment or through other pathways, to these really important downstream outcomes, which I would actually argue then kind of come back into the health picture, because these are huge outcomes, not just for financial distress, but eviction. Obviously, a lack of housing is a huge social determinant of health that we can look to. And all of the bankruptcy, third-party collections, you can just see that instability of what is happening in people's lives. And so I think kind of both are affecting each other potentially.
The next question I have is about the interaction of financial consequences and mental health. There's now a growing field of research about the financial toxicity of medical care, particularly in the cancer field, where people can be faced with very high expenses for new biologic therapies or chemotherapies, particularly if they have a high deductible health plan, or they have in the past had a lifetime limit on services they could be paid by their insurance. And we know from the Oregon Medicaid lottery that one of the main effects they saw was two main effects was across the board a reduction in financial stress when people in Oregon were randomized to be offered Medicaid coverage, and then about a 1/3 reduction in rates of depression, which was a bigger effect than they saw for any of the physical health effects. And I wonder if you could each comment on that, sort of what we might see, for example, Renu, in your data on mental health outcomes in the surveys that were collected. And Sarah, your expectations from that literature, thinking as a health economist about how financial toxicity may interact with mental health.
I want to say I'm glad we're talking about the relationship between mental health and financial distress, because I think anyone, even without any degrees of health or economics, can think about how that naturally makes sense. For the Oregon data, it is interesting that those two outcomes of improvements in depression symptoms and in financial distress were seen both hand in hand. And I would say for our data, we see it in two ways. One is at baseline, people who have more mental health conditions or impairments due to mental health conditions are having a harder time working, which makes sense. Lack of motivation, maybe there's other more serious mental illness, disorganization, and then thinking about whether it's through a pathway of health improvements, some of which we saw in our analyses, or through other pathways because of less financial distress, and having that be another pathway towards improved depression or other mental health outcomes. We see those associated with positive labor outcomes in the sense that people are reporting being better able to work or better able to get a job.
Yeah, I absolutely agree with that. I mean, I think one thing you keep in mind when comparing this to the results from Oregon is that, Oregon had a relatively small sample relative to what we have here. And so they weren't able to pick up on some of these longer term effects because they had a shorter follow-up period, and some of these more infrequent but important events like public records and bankruptcies. And so I would say that the effects that we see here are a bit bigger than what was observed in Oregon, and we see that they're growing over time, which is kind of new information. And so if I were to hazard an extrapolation, I would think that if there is a causal link between this financial toxicity and mental health, that it would be large and growing in Michigan relative even to the large effects that they found in Oregon.
I'd like to open it up to the audience. There's a question.
Yes, thank you for bringing that up.
Microphone just
Yeah, thanks for bringing that up. That's a great advertisement for my other work. So just how we planned it. I do have other work with the same co-authors where we don't have linked data, so we only have linked data from Michigan, but we have a very large nationally representative panel of credit reports that come from Equifax. It represents about 5% of the total national population. And in that analysis, we've compared not just Michigan, but all the states that expanded Medicaid to all the states that didn't expand Medicaid using, I won't go into the methodology, but essentially kind of like a difference in differences model. And there we find very similar effects for the collection variables. Now, we have a little bit less power on the bankruptcy variables. It pops up as statistically significant in some specifications and not others. And I think part of that is because we're limited to not knowing exactly who enrolled, which is an advantage of this data here. But that's a great point, and it does seem to be a benefit that's happening in all the expansion states, not just Michigan, relative to the non-expansion states.
To provide some direct data on the first question, which is about how many people are employed. We have at a baseline seeing that about half of enrollees are employed in our estimation, and we don't have a distinction in that initial whether that's full-time, part-time, but we're going to have more data on that soon. And I'm curious actually to see what Sarah says next, but for the cost implications of work requirements, that's been one of the ever-present questions in the national policy debate on this topic. And all we have right now are speculations and projections, which vary wildly from state to state. Kentucky put forward projections, Arkansas put forward projections about, millions of dollars more that it would cost to implement the work requirement. And I think, and it was interesting, our state Senate fiscal agency, when they did an analysis of the work requirement bill in Michigan, said, actually, it's going to save money because much of that is thought to be the expectation that people would be dropped from coverage. So trying to figure out how many people will be dropped from coverage versus how many people will stay in and what will happen to them in terms of their employment outcomes, I think that's kind of the question for we don't know. And I think everyone wants to know that in the states that are implementing it, to figure out if they want to do it in their state too. But I'm curious to see what Sarah says.
Yeah, no, I mean, I think you hit on the point, which is the way that the work requirements save money is they deter people from staying on the program, basically. And for people that can work, they can work and they can meet these hour requirements and stay on the program. But I think one thing, if you kind of look across Medicaid programs, the hassle costs of these type of programs can be so great that even people that would be exempt from the requirement might end up dropping just because it's difficult. There was a very interesting, I think it was a Kaiser Family Foundation survey that came out recently that showed that a large percentage of Medicaid recipients don't have the internet at home. They don't have access to broadband or the internet. Some of these work requirement proposals are requiring them to report their hours online. So it would be a situation where they'd perhaps have to take the bus to the library and use the computer there if that has internet access. So there's the economic reality is that if it'll save the most money, if it kind of annoys the most people off of or I shouldn't say annoy, but I mean if it deters the most people, whether they need the program or not, that's really where the savings are coming from.
May make a political addition to that, in that I'm not sure, even based on the language that state lawmakers are using, that it is for cost reasons that these programs are being implemented. In fact, in our state, the state senator who was really spearheading this said it's not about costs, and said that multiple times. It's about getting people back to work, and in a state where there's hunger for more employees. But there may be, that doesn't bring up, there may be a mismatch between the skills of the people who are needed versus the skills of the people who are available. But I think that is interesting. If it really comes down to costs, we'll have some answers in a few years.
Maybe I'll just take the last one first. I think a lot of economists are very much in the political minority in the sense that I think a lot of us feel like insurance is already too tied to work, that the employer-sponsored health insurance system that we have in the U.S. is sort of a artifact of IRS decisions made during World War II to exempt health benefits from taxes, which creates a very expensive entitlement to the middle class and a strong incentive to get health insurance through your employer, which we found can create all kinds of problems. Certain employers don't want to pay for certain types of health services. So my sense is that it would be healthier for the economy to try to decouple health insurance from work more than it is, not just for Medicaid recipients, but for all of us. Now, that's proven to be a very, very unpopular proposition that both the left and the right hate. So I'm happy economists can unify people over at least one thing.
And I will say to your first question, Jay, about what are the, most people think, and including myself, that it's probably going to cost more than it's going to save. And what do we do with that? And I think even if we do see that play out as expected, I do think most people are pointing to it as this is a political vehicle for either expanding Medicaid, as we've seen in Virginia, or maintaining Medicaid expansion. And that's actually the way it was framed in our state and several other states. So I don't know whether that's not inherently good or bad, but it is tied to that, I think, political reality. It's a good question. So the work we presented, wasn't specifically looking at gender differences and how economic disparities are impacted. But for the employment factors, which are tied to this, we did look at demographics that were associated and saw actually the bigger effects around age rather than, gender and race, ethnicity were also important, but what was interesting is in this labor market, for individuals who are 50s to 60s, so 50 to 64 would be the higher end of the age range eligible. Those individuals were less likely to be employed. Maybe some of those have retired earlier. I think others, as we see in our qualitative interviews, were facing age discrimination when they're applying for jobs. And so what was interesting is seeing those differences. So it's people who are in the older age groups were less likely to have some of the positive outcomes, and probably there's some speculations within our team was that maybe that's related to age discrimination. I think for the gender differences, there's a lot of larger body of work, and maybe actually John would want to comment on the larger body of work.
Sure. Well, the way insurance is allocated in this country oftentimes is tied to gender. So in the traditional Medicaid program that predated the Medicaid expansion, probably 2/3 to 3/4 of enrollees, of adult enrollees, are women, and that's because many women qualify either for pregnancy or as the single parents of dependent children in many states. Whereas what's interesting here in the Healthy Michigan Plan, this program that was for low-income adults, whether they had children or not, it's about half and half, men and women. So, I think we see, at least in that sense, men who, without children, say, are oftentimes more likely to be uninsured than women, may be getting some extra benefit from this program because it doesn't have those statutory requirements about either being pregnant or being a single parent. I think it's tougher. You raise a good question that maybe we can look at in some of our future work, because we're continuing. Renu presented our data from the 2016 survey findings, but we've just finished conducting our 2017 survey about 6 months ago, and we're now getting ready to go into the field with our 2018 survey. So we'll also be looking at changes over time in some of these health and economic effects. And you raise a good point, both how we can look at that by gender as well as by age and potentially the interaction of those two. I think, as Renu pointed out, over age 50, if you have chronic health conditions, it becomes much more difficult to get, to meet a work requirement. In fact, Arkansas, for their work requirement, limited it to people under age 50. And, it may be from a policy standpoint quite reasonable for people in their 20s and 30s who are in good health, not with significant medical conditions, to be strongly encouraged to work like this. But somebody who's 60 with 3 or 4 chronic conditions, and some functional limitations because of that, is going to find it very difficult to work. And, and that's the group that's going to be most disadvantaged, whether they're men or women, if they're cut off from Medicaid because they couldn't meet the work requirement.
That's a great question. So that's something that I could potentially do with this linked data, that's a very interesting idea. In previous work I've done with credit report data, it hasn't been possible because actually on your credit report they have very little demographic information except your age. So you don't even know gender or anything like that on a credit report in the sort of data that they allow researchers to use. So I actually don't think there's any even stylized facts about gender differences in repayment rates because of this data limitation, but that's definitely something we could look into going forward. Thank you.
That's a really interesting point about how Medicaid expansion may be associated with mortality, and particularly I think the implication you're raising is for those with mental illness. Do we see any changes in suicide rates or other kind of, unintentional overdose and all that kind of stuff? We don't know yet with our data, but I would say looking at some other data, I know there's been other work by other investigators looking at the association between state Medicaid expansions and mortality, where they've actually found an effect on decreasing mortality. And I think of Ben Summers' work in particular in that area. For the suicide rate, or like having that be tied to mental health, I don't know of anything that's I don't know if you know.
I don't think there is any
Yeah.
good literature on that. And it may take a few years till we have more experience. The Medicaid expansion really only began, as Renu indicated, at the beginning of her presentation in 2014. And so, we start now to have data through 2016 or 2017, and we may just need more time to look and find out whether those effects are borne out. I think we're right at 5 o'clock. Thank you for the opportunity to present.
Thank you.
Yeah, thank you all.
I get to do the fun part here. Just a little token of appreciation. John?
Thank you.
These are Petoskey stones, a little engravement there.
Oh, awesome. Thank you.
So nice. Thank you so much.
Okay, thanks so much.
Thank you.
There is a reception of some nice food. It's a great opportunity. This is really a very timely topic that was discussed, so get a chance to mingle with the speakers and ask them more informal questions. Thank you so much.
Okay.